Okay, it's time to move on. We have a final presentation, and then we're going to learn how to deal with the mitral valve. Oh, sorry. Well, I'm sorry. We have to move on. Maybe at the next session. Yeah, Dr. Saric, please go ahead.
So it's a pleasure to be here. I'm neither a surgeon nor interventionalist. I'm an imager, so I'll provide you an imaging perspective to this. And I'm sorry to disappoint, but the word LVAD or RVAD will not be mentioned in my presentation. So these are my disclosures. And this is the overview of presentation. I'll give you a few overviews on imaging of the mitral valve in this condition. We'll mention although there are multiple forms of acute mitral regurgitation, its etiology, I'll discuss one given the time constraints. And if you would like the larger version of this presentation, I can share with you. And there is a series of questions where you can test your knowledge. So let's start with an overview of acute mitral regurgitation and why the imagers are important for this condition. As you know, any manifestation or clinical manifestation of valvular disease is a combination of a valvular pathology itself as well as the interaction with the respective ventricle and the atrium. And while chronic mitral regurgitation is a common finding in the intensive care units, it's really a combination of a valvular regurgitation and the remodeling of the left atrium and the left ventricle. What the acute mitral regurgitation is physiologically fundamentally different is dominated by the valvular pathology. And mere absence of LV and LA remodeling is a key, diagnostic key, that this mitral regurgitation is an acute. We can expand this finding, then it says the regurgitant volume and left heart chamber sizes are the key to recognizing that the mitral regurgitation is acute or chronic. And it's clearly that large regurgitant volume in acute mitral regurgitation is emptied into a stiff, non-dilated left atrium and left ventricle, leading to a massive pressure overload and a condition that it's truly suddenly elevated and a life-threatening condition, acute mitral regurgitation that requires immediate medical, transcatheter, or surgical intervention, as opposed to chronic mitral regurgitation that contributes to mortality and morbidity of patients in intensive care unit, but it's not an emergency. But interestingly, all the guidelines that we have actually deal mostly with the chronic mitral regurgitation. With the acute mitral regurgitation is devoted only 1 to 2 paragraphs in the leading guidelines that we have. And how do we establish the diagnosis of mitral regurgitation and help guide the treatment? So first, we have to detect that mitral regurgitation is present and quantified. Luckily, most of acute mitral regurgitation tend to be very severe or torrential. We'll establish the etiology of mitral regurgitation because that drives the type of treatment. And then key is demonstrating that there is a presence of non-dilated left ventricle and left atrium, unless clearly there is a pre-existing condition. So how do we detect and quantify mitral regurgitation and guide it really that this is an acute mitral regurgitation, an acute medical condition? We'll rely on color Doppler that you'll have seen it everywhere. It's, again, what a multiple quantitative technique based on color Doppler. It's not difficult to recognize severe mitral regurgitation because most acute mitral regurgitation are severe. Here we'll get the sense that this is an acute because left ventricle is not dilated and there is a preserved ejection fraction. We'll do a spectral Doppler, which is give us typically the way that it is, triangular, low velocity, triangular shape, elevated velocities and the antegrade velocity, and then E-dominant pattern of flow. And if you just compare this would be an acute severe mitral regurgitation as a chronic severe mitral regurgitation, they'll both have antegrade velocity increase because of the high preload, but you'll see the triangular shape of acute mitral regurgitation as opposed to parabolic shape of chronic mitral regurgitation. There are other signs, as we already discussed, mitral inflow, the presence of pulmonary venous return, systolic reversal in pulmonary veins is characteristic of all severe mitral regurgitation, but particularly of acute mitral regurgitation, and the presence of pulmonary arterial systolic or diastolic hypertension. Etiologies are multiple. Any part of the mitral apparatus can be responsible for acute mitral regurgitation, from endocarditis to blunt or sharp trauma. But one that I will discuss with you in 3 minutes is a ruptured papillary muscle. The patient, 54-year-old, sudden respiratory distress. He has no prior medical history. We are in the midst of COVID pandemic when this case occurs, and precious hours are lost chasing the COVID diagnosis. But rapidly then evaluated, he's hypotensive, tachycardic, hypoxemic respiratory failure with the metabolic acidosis. Chest X-ray, massive pulmonary edema, which is unilateral partly, which is not unusual for the acute mitral regurgitation. By this time, he is intubated, has a Swan-Ganz catheter, and markedly elevated wedge pressures. Interestingly, EKG didn't show ST elevation. There was even only minor troponin elevation, but still the diagnosis of NSTEMI, cardiogenic pulmonary edema, and cardiogenic shock was established. Transthoracic echocardiogram again shows a severe mitral regurgitation, and these regurgitations tend to be eccentric. So there's a large piece of formation, eccentric, wall-hugging jet, known as a Kwanda jet. If you ever wondered who Kwanda was, he knew nothing about echocardiography. He was an aeronautics engineer. And this is his plane. He just essentially, he almost died because of Kwanda effect. You can read about it. And then this is this patient. You see that there is infralateral hypokinesis, non-dilated left atrium, and there is something mobile in the left ventricle. You see there is a large piece of meat attached to the ventricular side of the mitral valve. There's a ruptured subhead of a posterior medial papillary muscle. Doppler is, again, it's a character low velocity triangular jet, increased antegrade velocities. Cardiac catheterization shows both the right ventricular RCA disease as well as left circ disease, but the normal LAD balloon pump is placed as appropriately, and then he's immediately taken to the OR. What do we see in the OR? Again, a large piece of meat. There's a ruptured papillary muscle, posterior medial papillary muscle, mitral chordae, and the piece of meat. And then again, Kwanda effect, severe mitral regurgitation. And then it's, as you know, this papillary muscle has a single vascularization leading to high incidence of this in this part of myocardial infarction. Recognize it immediately as acute surgical intervention, mitral valve replacement, cabbage, and this is the specimen, and acute myocardial infarction. So this is the summary: ischemic mitral disease, subacute myocardial infarction, leading to mechanical complication, appropriate treatment. So epilogue, 3 years later, he is doing very well. So thank you very much in these 7 minutes. I really appreciate it.
So fantastic presentation. And I think what I'd like to do is put it in a sort of bit of a broader context and see what our panel thinks and questions from the audience, and even last presentations. But it really brings up this idea of sort of acute cardiogenic shock from mechanical complications, whether it's a ruptured papillary muscle, VSD, these things. And historically, it was a balloon pump, take them to the OR right away. But as he showed, once these patients are intubated, hard to ventilate, we can actually replace their valve and whatnot, but then it's very difficult post-operatively to try and manage them. There's multiple case reports now suggesting, though, that you can put an Impella in many of these situations, stabilize them, and at least get them a bit more stable before you go to the OR. So does anybody have any experience, recommendations?
Yeah, I mean, so we gained a lot of experience in the post-infarct VSD during the pandemic, and now our routine is we'll put an axillary Impella in most mechanical complications, but especially the post-infarct VSD, and we park them for 4 weeks with that in. We were worried that there would be an issue with hypoxemia. We haven't seen it, and we're able to then, after 4 weeks, go and do, it's essentially a congenital heart operation. One of the things I've noticed is that in 100% of these cases, and we've done about almost 10 of them now. I think we did 9 or 10 in the last 3 years. The septum is entirely gone when we go back in 4 weeks. There is no septum at all. And so what we used to think surgically is, oh, okay, we'll go far out on the septum, still take bites on the septum. No, this becomes a, single ventricle, no septum, like AV canal kind of situation. And we go in and we created a new septum, and the patients do incredibly well. We haven't written it up. We need to do that, but that's our routine at Emory.
Have you done mitral ruptured papillary muscle? Because there's concern about the rotating blade and ingesting the meat into that and causing failure. Have you done it?
I've done one, and I supported them for 2 days, and then I went and replaced the mitral valve for that same reason. But they were, super sick. As soon as their lungs started getting better, I did it.
No, so I would avoid an Impella in that situation. And I've done VA ECMO, and VA ECMO either via an axillary graft and a venous cannula so they can ambulate for that reason, so they can decongest and perfuse the end organs, recover before I go in and fix the valve. But I haven't, for VSDs, yes, for the Impella, but no for the MR.
So I think both the VSD and the ruptured papillary muscles would be great for LAVA, because the whole point about decongesting the left atrium in both of these pathophysiologic processes would be phenomenal, because that's what it is. It's a high left atrial pressure system, and any way you vent them or support them to get the LV-EVP down, it's a contiguous system. That makes sense to me. What are your thoughts?
I respectfully disagree with that really quick if I can. For the VSD, I think it's important to be able to support patients for longer than a couple of days or a week, because you want that septum to disappear and you want all the edema to go away. It becomes a really easy operation 4 weeks later, and I don't think you can support somebody safely with LAVA for 4 weeks.
Yeah, we had quite a bit of experience with the tandem heart actually for both, so of course it's difficult to put it in, much more difficult than Impella. But Impella, it can have its own issues, like Marvin said, ingesting the meat, especially if you have a piece of meat hanging in the mitral regurgitation, like this case. Then obviously Impella, it's a little bit higher.
Probably for the mitral, I think it's okay, but I think for post-infarct VSD, again, my personal bias is you need to wait 4 weeks. It makes it a very technically easy operation.
Our cardiologists closed them before 4 weeks.
Yeah, we did close it. Actually, we had like 10 days pre-op and then post another week.
I think it'd be really useful to go back and really look at the data, as far as closure. I mean, you're arguing that the septum should basically involute and be gone.
Yeah.
And most people would say no, we still could patch it. And if, so I really think we should look at that data before, and you have to write up your series.
Yeah, we need to write up our case series.
Right.
Yeah.
And I'm going to quickly clarify for Dr. Danishman. He
hearsay,
doesn't want the septum to go away. He wants it to delineate itself as to what will be the fibrous part. He
But
doesn't
it
want
does
to
go away. Yeah. It almost always goes away, yeah.
All right, Ollie, last question. Oh, sorry, we have one more here then, too.
Thank you. I think it makes perfect sense to keep the patient 4 to 6 weeks on temporary support for VSD. But for acute mitral regurg, how are you going to protect the lung? Because you might be able to keep the lung flooded with blood. Even with Impella, you will not be able to protect the lung. Yeah. That needs surgical intervention. Any delay might be associated with more ARDS and more complication post-op.
Yeah, that's why I bring it up, though, because people are trying multiple different things, and the issue is what's the best approach in timing, particularly for acute mitral insufficiency.
But if you have flooded lungs when the patient gets to your hospital, take him to the operating room and then doing VV post is an option, but it's probably not the best outcome. Decongesting the patient, stabilizing the hemodynamics, treating the pathophysiology, and then operating on them in one stop. And we've done this, and we've had people who came to us on VV because they came in the hypoxemic door, and someone in the field puts them on VV, and then they call us, and it turns out they had a ruptured mitral and they didn't see it, and then you waited at that point. But go ahead.
Right, last question over here.
I think thank you for all your comments, Arvind Bhimraj from Houston here. In a VSD or an acute MR, the physiology kind of is an unloaded LV, so it gets very difficult for the Impella to unload effectively. We've had challenges leaving it in. As Dr. Gregoric mentioned, the left atrial unloading physiologically makes sense. But my question is, as anybody has a better experience of doing the left atrial unloading with an axillary approach or a minimally invasive, so you can ambulate people and keep it longer? Because a few tandems we've done, we're kind of forced to go to the OR and they still don't do well.
Anybody from the panel? We have not done it.
Yeah, we've not done it.
We were just talking. So I asked whether you could do a transeptal from an IJ or a subclavian vein approach to put the cannula there to allow ambulation with an axillary outflow.
Yeah, and it's feasible, but it's a lot harder.
Yeah, and again, experience.
But it sounds like it's right for someone to try, one of you young people who wants to work in the middle of the night. I try not to do that.
All right, final comment, final question.
For acute MR in our institution, that's viewed as a surgical emergency. and we don't try and temporize much more than getting the patient into the operating room and then dealing with the subsequent issues post-operatively. And don't the guidelines kind of reflect that it's a surgical emergency?
Yeah, so the answer is absolutely, and I think we all agree it's a surgical emergency.
Right.
The problem, though, as Dr. Silvestri pointed out, though, is once they're intubated, essentially they're going to require VV ECMO, or they're sort of in that scenario. Is going to be extremely difficult to, I mean, you can replace the valve, right? But the answer is then what are you going to do? You have to come off on VV ECMO and whatnot.
Yeah,
and there certainly
the
is.
lungs are whited out so that you do need VV to
Right.
support, but the physiology is very difficult to treat without repairing the valve immediately. Thanks.
Yeah, no question. Well, on behalf of Dr. Gregoric, we want to thank all the panelists and our outstanding speakers. I think this has been an outstanding session. I actually learned a lot. And as the judge and jury, though, I'd like to give the debate award to Dr. Billy and Dr. Wald for an outstanding debate, and what at times seemed a little bit personal, but I'm sure it was all fun.
Thank you. Thank you very much.
Thank you. That's fine.
Ladies and gentlemen, we are now scheduled for a 10-minute break. 10-minute break.